Bedside examination of the aorta is an essential tool for emergency physicians. Today we'll be talking about the application of ultrasounding the aorta, including the specifics of how to not only perform the technique, but also to accurately interpret your findings. Identification of an abdominal aortic aneurysm is, of course, an essential part of emergency medicine practice. It's a potentially catastrophic disease and has resulted in great morbidity and mortality in the past. Typically, it's dealt with by surgical therapy, although there are endovascular techniques to address the situation. The point is, early detection is the key. The definition of a AAA is somewhat variable. For our intents and purposes, a AAA is defined by any aortic diameter that exceeds 3 centimeters. This corresponds to greater than 150% of a normal aorta. From an epidemiologic perspective, approximately 15% of AAAs will ultimately rupture. It's a leading cause of death in the United States, and also is the 10th leading cause of death in males greater than 50. So if there's a target population, it will be older males who are also smokers. There is some suggestion that the incidence is also increasing, which may be due in part to better efforts to identify the pathology. In this case, size is very important, as the radius and/or diameter of the aneurysm increases. The risk of rupture within the next 5 years increases tremendously. For aneurysms greater than 7 centimeters, the 5-year rupture rate exceeds 75%. There is a law that governs this, and you may remember this from way back in the day. This is Laplace's law, which states that the larger the vessel radius, the larger the wall tension. So as the AAA increases in size, your chance of rupture increases tremendously, as discussed. As it is a disease of the elderly, this is a population we have to be concerned of. The mean diameter does increase with age, although the median diameter, interestingly, does not. Approximately 4% of males greater than 55 have an aortic diameter of greater than 3 centimeters. In males greater than 65 who have a history of smoking, the prevalence may exceed 10%. It turns out that not only radiologists, but also emergency physicians, family practitioners, techs, nurses, anybody can go through a teaching session and accurately perform ultrasounds of the aorta. After a 2-day training course, in a study, it was noted that there was 100% sensitivity, specificity, and accuracy. While the emergency physicians weren't perfect, it turns out they are able to perform the scan as well with a sensitivity that exceeded 90%. The two false negatives were accounted for by an aortic dissection, as well as inaccurate placement of the calipers on a AAA. But in general, most medical providers have been shown to accurately perform this study. As the ultrasound modality is inexpensive and rapidly available, it's your go-to modality for any patient's concern for a AAA. There's no interruption in patient care, and the patient does not, of course, go off to a radiology suite, which would put them at greater risk. It also provides some added information regarding possible free intra-abdominal fluid, the extent of the aneurysm, as well as involvement of other vessels. Finally, you can accurately identify clot, as well as the potential for an abdominal aortic dissection. The AAA exam involves a unique understanding of the retroperitoneum, as well as typical sonographic technique when it comes to the abdominal ultrasound. The probe is held in 2 different orientations typically during this exam. The first orientation, which should be familiar to you, is the transverse or short axis orientation of the aorta. The probe pointer is towards 9 o'clock, and the probe is held high in the mid-epigastrium. Additionally, the probe can also be turned with the indicator towards 12 o'clock, which would be a longitudinal or long axis orientation to the aorta. Starting off with the transverse orientation, as you can see in the picture, the probe is held like a pencil. Firm pressure is oftentimes needed in order to displace the bowel, and we're essentially using the liver as a sonographic window to adequately visualize the abdominal aorta. When you do this, this is what you find. You see, first of all, a vertebral body as designated by V, and then just anterior to that, you see the abdominal aorta. On the left of this image and the right of the patient is the IVC, which in this case is somewhat flat. And then there's a superior mesenteric artery, which is a brightly echogenic structure just anterior to the abdominal aorta. And the final structure I'd like you to recognize would be the splenic vein, which courses over the SMA and will eventually form the portal vein. Now, taking a look without the labels, this is your typical upper aorta image when you first place the probe on the patient's mid-epigastrium. The first thing I'd like you to identify, once again, would be the vertebral body. Now, taking this a step further, as we move down the abdominal aorta, the first structure that's noted is the celiac. Okay, so the celiac trunk actually appears as a seagull sign, so it almost looks like a seagull as it comes off of the abdominal aorta. So watch this video, and you can see the two branches of the celiac, one going to the splenic artery, the other going to the hepatic artery. The rest of the structures, as discussed, are now seen on the screen as well, including the superior mesenteric artery as well as the splenic vein. So give it another whirl here. Go ahead and test yourself. What's the first thing I'll ask you to look for? That will be the anterior cortex of the vertebral body. Then we know just anterior to that will be a pulsatile, thick-walled structure, which is the transverse of the aorta, the superior mesenteric artery just over that, as well as the splenic vein coursing over the superior mesenteric artery. The probe that tends to be used is a 3.5 megahertz transducer, a curvilinear, although a P17 or cardiac probe can also be used. Sonographers are asked to measure outside wall to outside wall in the transverse orientations, and recording images of maximal aortic diameter at 3 different levels, a transverse high, mid, and low. The key, of course, is real-time methodical scanning, however. This demonstrates a transverse high aorta in which we have calipers placed outside wall to outside wall. So there's a little bit of the luminal wall that is included in the measurement. The idea is not to underestimate the size of the aorta. This is an example of the mid-aorta. And then finally the low aorta. The ideal location for this is just above the bifurcation into the iliacs. Follow this normal real-time transverse aorta exam. As we course through the abdomen, we approach the point at which the aorta will bifurcate into the iliacs, and we're looking for any focal dilatations. Here is the abdominal aorta, and it's about to approach the point at which it bifurcates, which is about right here. Let's move on to the longitudinal views. This is obtained by placing the probe in the mid-epigastrium with the probe pointer at 12 o'clock. The idea is not to miss any focal dilatations of the aorta. The problem here, however, is there can be a little bit of difficulty distinguishing between the IVC and the aorta. Once you become used to this technique, you tend not to make this mistake. However, for all intents and purposes, we should discuss IVC versus aorta. The IVC tends to be a thinner walled structure. Anatomically, it's going to occur on the right side of the patient. It may be larger or smaller depending on the hydration status, but it does not have any anterior branches. This is in contrast to the aorta, which is a thicker walled structure, which does have several branches. To convince you, let's first of all look at the IVC, which is seen here in longitudinal. There is the branch, which is actually the hepatic veins dumping into the IVC, but no other branches to the IVC, versus the aorta, which has several branches, a thicker walled structure, which is also brightly echogenic. Convince yourself by comparing them at the same time, with the IVC on top and the aorta below. Those different branches that we discussed correspond to the celiac as well as the superior mesenteric artery, which runs in a parallel fashion to the aorta. Now let's take a look at this in real time. I've added color flow to the image down below just to prove to you that this is indeed the aorta. This is the aorta and the SMA that's just anterior to it, with the celiac that branched off at the early part of the aorta. On the upper image without the color flow, this is what you would see if you were doing a very standard longitudinal evaluation from the diaphragmatic hiatus all the way down to the bifurcation into the iliacs. Let's discuss some pearls and pitfalls. The biggest complaint I tend to get from most training sonographers is the issue of bowel gas. Patients are too obese, they're too gassy, having a hard time identifying the aorta. This is one of the few exams where probe pressure really does make a difference. I'll recommend constant firm probe pressure as well as jiggling the probe on occasion to try to disengage the bowel. The idea is with constant firm pressure, peristalsis will occur and it will get out of the way of your probe. More pearls and pitfalls, and this is probably basic to most of you. A small aneurysm identified does not preclude rupture. If you do identify AAA, it may not be the cause of the patient's symptoms. There may be some other pathology at play, including an aortic dissection. Just because you rule out free intraperitoneal fluid by a fast exam does not mean the patient does not rupture their AAA. It turns out that the vast majority are simply retroperitoneal bleeds. Unfortunately, those same retroperitoneal bleeds cannot be reliably identified by emergency or bedside ultrasound. And finally, saccular aneurysms, albeit rare, are indeed easily overlooked, so a methodical scan is key. My next comment about pitfalls regards caliper placement. As you can see in these two cases, the calipers have been mistakenly placed. In this first one, the caliper has been placed right here, whereas this is all clot. Indeed, this is the aneurysm from the point of my cursor all the way down to this posterior wall. Over here, again, they've underestimated the size of the aneurysm, which starts about here and ends about here. Finally, to emphasize once again, real-time scanning is the key of this, although we do need to document what we're doing. This will involve two orthogonal planes for any noted pathology that we discuss. For a QA perspective, the documentation will include 3 transverse views, which will be transverse high, mid, and low, labeled with calipers from anterior to posterior, outside wall to outside wall, as well as 1 or more sagittal views or longitudinal views from the celiac to the bifurcation. So let's move on to various pathology associated with the abdominal aorta. Starting off with our first clip, I want you to notice first of all the anechoic area, which is the lumen of the abdominal aorta, surrounded by some gray level echoes. This is clot surrounding the lumen. And actually the true dimensions of the abdominal aorta are outlined by the cursor. So this is over 7 centimeters. Another example of the same pathology is this 5 centimeter abdominal aortic aneurysm. We're moving from a transverse to a longitudinal. You can see the same gray level clot with the actual lumen. Now sometimes when you're evaluating for a AAA, you may find alternative diagnoses. For example, an aortic dissection, hydronephrosis, gallbladder pathology, intraperitoneal free fluid, etc. The idea is just to keep an open mind to this. In this example of this clip, we see now a transverse orientation of the abdominal aorta, flipping between the transverse and longitudinal, and the first thing that's striking is that within the lumen we see an echogenic area that's flapping around. This is actually an aortic dissection. Importantly, it's rare to have an isolated aortic dissection in the abdomen. Usually it derives from a thoracic aortic dissection. Here's another example of the same pathology. Almost looks like a valve, which of course you would not expect to find within the abdominal aorta. We're moving from transverse to longitudinal. We see that same echogenic flap. This is at the level of the celiac trunk. So let's move on to a case. Let's imagine you're working in a community ED when a 60-year-old male comes in by a fire rescue. He had a syncopal event, comes in tachycardic, hypotensive, hypothermic. It's a relatively sick individual. You do an exam on the patient, and he's confused. He has clammy extremities, pulses are thready, and you do a bedside ultrasound. You're looking for an etiology. Could be septic shock. This patient could have hypovolemic / hemorrhagic shock. We're not sure exactly what's going on. We look at the lower aorta, and the AP dimension is about 35 millimeters. So nothing too remarkable at this time. So here's the point to doing a full methodical scan. The next dimension is in excess of 73 millimeters. So this is a huge abdominal aortic aneurysm. If you did a clip, this is what you might see. Same idea of a lumen surrounded by some clot. The idea here is that you have decreased laminar flow on the periphery of this large aneurysm, and that sets up the stage for developing clot. Interestingly, if you turn this into a longitudinal, it looks just about the same. So the idea is in a spherical structure, it may look the same both in transverse and long. So don't be surprised. So, what might you feel if you performed a physical exam on this patient? Well, chances are you'd feel pulsatile mass. That's also expansile. So physical exam is helpful. It's not great. The sensitivity is reasonably poor, but you're not going to hurt the patient. You're not going to pop the aneurysm. And this has all been, of course, studied. Unfortunately, the patient's presentation is not very helpful. Only about a quarter of patients will present with that classic triad of abdominal pain, hypotension, and a pulsatile abdominal mass. Most of the time we misdiagnose this as renal colic, as diverticulitis, or some other pathology. CT, of course, is great for this, but that takes the patient out of your resuscitative suite. That also exposes the patient to perhaps unnecessary radiation, but sometimes this can be a helpful modality. Let's take the second case. If you have a 60-year-old male who comes in after having had a fall, you perform a FAST, which is negative, and you take a look at the aorta and you see something markedly abnormal. So this patient has a AAA, so what do you do with this patient? Here's an example of the longitudinal with a fusiform aneurysm. Follow the lumen down, and then you see the dilatation of the abdominal aorta. So it turns out that surgeons tend to operate on these. So in the U.S., AAAs greater than 5 centimeters will undergo procedures, perhaps not now, but in the future. So it's something that you need to discuss with your consultant and make a disposition accordingly. Screening is kind of a hot topic. We already know that the prevalence of AAA in males greater than 55 is around 4%. In males greater than 65 who are smokers, it's much, much higher. So there may be a value to performing these evaluations even in asymptomatic patients. Symptomatic AAAs are quite easy. If the patient has abdominal pain and they have a AAA, then you're going to get a surgeon involved. Okay. Also apply this to any patient with unexplained hypotension. So now that we know the background, we know how to do the study, let's talk a little bit more about the various pathology. I want to give you a few more examples. So this first example is moving down inferiorly in the transverse orientation of the aorta, and we see an approximately 4 to 5 centimeter abdominal aortic aneurysm. I want you to notice on here that due to the fluid, we see a nice example of posterior acoustic enhancement. We also see some lateral cystic shadowing or edge artifact. Okay, but then we see a large abdominal aortic aneurysm. Moving on, we see another example of the same pathology. We see a normal lumen and then followed by a dilation of the aorta. This is a fusiform aneurysm, which of course is the most common. It's very rare to have a saccular aneurysm. Every once in a while you look for a AAA and then you find something that's completely different. So take a good look at this. The first thing I want you to identify is the anterior cortex of the vertebral body. We see the IVC, and then we see the aorta, and then we see something within it. Almost looks like a little web, an echogenic structure. That is a dissection flap. So this is an aortic dissection. This is another example of that same pathology. So we're looking, based on the arrow that's pointing at the pathology, we see a dissection flap once again. If we follow this down, it turns out that this dissection flap will actually extend inside the iliac artery, and we can make a disposition based on this ultrasound. This final clip gives you a good comprehensive example of what you might find in terms of pathology. This sonographer is measuring both anterior, posterior, as well as lateral dimensions. And we know right off the bat in this relatively sick hypotensive patient that the abdominal aorta is quite large. So we measured the high transverse aorta, now we're in the mid transverse aorta. And note how they're doing outside wall to outside wall. And we see that measurement is almost 8 centimeters. So this is something that we're going to be acting on immediately. The final measurement is a distal measurement. And again, greater than 90% of AAAs will occur just below the renal artery, so infrarenal AAAs. And then with this final dimension, it's always helpful then to do a quick fast exam. And what we find here is that there's a marked amount of free intraperitoneal fluid. So this is a very sick patient. So let's bring it back to the beginning. Our QA requirements. We're going to ask you to perform 3 transverse views: a transverse high, transverse mid, and a transverse low, and then turning the probe up 90 degrees towards the patient's head, a longitudinal. Any pathology, of course, should be examined in 2 orthogonal planes, and also views of the iliacs can be obtained if clinically indicated.